Bismillahirrahmanirrahim. Jana Salman, co-chairs, distinguished guests, ladies and gentlemen. It's a great pleasure to be with you, even though 11,000 miles away near midnight in California at the moment. I'm very grateful to Dr. Farah and her team for inviting me to give this talk. I've been asked to talk about necrotizing enterocolitis because it's a disease which is a continuing enigma for neonatal scientists like me who work both at the bench and clinically, and it is a continuing enigma for basic science researchers. For this presentation, I have nothing to declare and no conflict of interest. Necrotizing enterocolitis is a devastating disease, particularly for the very fragile and preterm infants. Though we have known it for nearly 200 years, and for the last 60 years, we have been researching it very, very thoroughly. But despite that, we really don't know very much about it. The knowledge is increasing, but we do not know its exact pathophysiology, how to prevent it, and how to treat it. But I was thinking about, when I was asked to talk about necrotizing enterocolitis, whether it is a relevant talk for Pakistan or not, I looked at the scope of the problem. The incidence of necrotizing enterocolitis throughout the world varies between 2 and 11 or 12%. I just want to point out two things from this particular slide. If you look at the North American incidence, which is about 7%, the same number of babies with necrotizing enterocolitis die as the total number of children under 15 years of age with cancer and meningitis in the United States, in North America. In Pakistan, the only paper I could find is from Hashmi et al. From Haque University Hospital, where they've quoted an incidence of necrotizing enterocolitis of 9%. That means an approximately 42,000 newborn babies get necrotizing enterocolitis in Pakistan. And if you look at the current mortality rate, about half of them would die. So I think it is a relevant subject to talk about, and hopefully I can make the subject easier to understand in these next 20 or 30 minutes. Whilst many units have taken measures to reduce the incidence and the frequency of necrotizing enterocolitis, for example, our own unit has an endemic rate of about 3%. Neonatologists around the world still continue to overdiagnose and overtreat necrotizing enterocolitis. So much so that in the United States, a single surgical case of NEC costs something like $500,000. And the overall cost in the United States of treating NEC in the US is between $500 million and $1 billion. So it is a disease which not only kills, but is expensive to investigate and expensive to treat. But we continue to diagnose it and overdiagnose it. Why is this? The reasons are just two, in my view. One, there is no clear definition of what NEC is. And the second is that most clinicians still have a conventional understanding of the pathophysiology of necrotizing enterocolitis. Just to give you an example why this lack of clear definition, what it means clinically. Here are 7 babies. Their abdominal pictures are in front of you, and their abdominal x-rays are there. They were all diagnosed as necrotizing enterocolitis. Only one of them has it. I'm not quite sure if you can guess which one. But what happens is that we as a neonatologist tend to lump anyone with abdominal distension and a dubious abdominal x-ray as necrotizing enterocolitis. So much so that 2 years ago, or 3 years now, Ravi Patel was at a meeting This was a meeting in US of neonatologists interested with particular interest in NEC and neonatal surgeons with particular interest in NEC. And you know there are about 8 or 10 published definitions of NEC. Of these, he asked them which definition were they using. Most textbooks tell you Bell's classification staging. Only less than 5% of current neonatologists use that classification to diagnose NEC. Most use modified Bell's. There are 4 modifications. We don't know which one is more popular, but majority of the US neonatologists and neonatal surgeons use that definition. And not surprisingly, they were not using the NICE definition because they are based in US and the NICE definition is the UK definition. But interestingly, the Vermont-Oxford network, which is the largest network of neonatal units in the United States, its own definition was only used by 20%. The surgeons are much more keen on this new definition, which is called 2 out of 3. There are 3 parameters, and if 2 are present, then they think the baby has necrotizing enterocolitis. But I think what is important is the last figure, that 18% of people in that meeting, which was geared for neonatologists interested in NEC, were not using any of these definitions. So for this particular talk, my definition, which I have published and used, is NEC in an idiopathic inflammatory bowel disease mainly seen in premature infants that involves small and large intestine. It is characterized by coagulative necrosis. And coagulative necrosis is an essential part of NEC. There are inflammatory changes, bacterial overgrowth, pneumatosis intestinalis, and perforation. But coagulative necrosis is the classical feature of NEC. Now, the old concept of what NEC was that you have a baby with hypoxia. When the baby is hypoxic, the blood is redistributed to the main organs away from the gut. And so the gut becomes ischemic. And if there are bacteria already present there and the nutrients coming mainly from formula milk, these 3 things combine, then you get necrotizing enterocolitis. We have moved far, far away from that. There are many, many more variables. But the 3 which are most important are the intestinal immaturity, the bacterial expression and overgrowth of opportunistic bacteria, which Talal was talking about, but more importantly, it is the immunoreaction or immunoreactivity of the gut mucosa, particularly of the preterm infant. So if you look at if I summarize the pathophysiology of NEC currently as we understand it, it is intestinal immaturity plus excessive immunoreactivity of the premature intestinal mucosa, plus the microbiomes and nutrients which are in the gut. So that is basically what we understand currently as a pathophysiology of NEC. Now, why do we lump them together? Because a lot of babies present with abdominal distension, and the most common one which we usually confuse with NEC is so-called the spontaneous intestinal perforation. As I pointed out here, there is just a little hole. There is no inflammation, there's a rupture, and there is no necrosis, and there is no surrounding inflammation. The spontaneous intestinal perforation occurs much earlier than what you would expect necrotizing enterocolitis to occur. So SIP is one of the most important differential diagnoses, both for surgeons and for neonatologists between NEC. But there are 5 others, and these are viral enterocolitis, which again is due to immunoreactivity and a viral infection, but there is lymphocytosis in that. Milk protein associated because there is sensitivity to cow's milk protein, and the damage is basically done by the collection of eosinophils which break down and release the eosinophilic granules, which are enterocyte toxic. Then there is talk about, we have known of transfusion-associated necrotizing enterocolitis, and this was thought to be due to the presence of antigens to the intestinal epithelium in the transfused blood. But this theory has now been debunked, and I'll tell you why this theory doesn't exist anymore. One of the most common cause of necrotizing enterocolitis is delayed feeding. If you don't feed the baby, the bacteria grow, and particularly there is disbalance or dysbiosis between good and bad bacteria, which Talal was talking about. And there is also, if you give antibiotics, you preferentially kill off the good bacteria, and the bad bacteria grow much more rapidly. There's also, if this is done in a premature infant, there is an exaggerated immunoreactivity, which I will talk about. Then, of course, there is gut hypoxia or gut ischemia if the baby is hypoxic, or there is left-sided congenital heart disease, which reduces the mesenteric blood flow. So there are these 6 conditions which frequently present as what is diagnosed as necrotizing enterocolitis, and we lump them together. Mercifully, only this year, last year, a paper was published by Sun et al. What they have done is large data. They have gathered the large data and started to put them in machine learning. And now we have a tool which is available at research level to be able to differentiate between these 6 conditions with a sensitivity reaching about 90%. So hopefully we will be able to use machine learning and machine tools to differentiate between these differential diagnoses. I don't need to go through this. Everybody knows that the risk factors are prenatal, perinatal, and postnatal. The important ones are the gut microbiome of the mother, the chorioamnionitis, prematurity per se, but more importantly, postnatally, is formula feeding, antibiotic use, and of course, one thing which has also come across very significantly in new research is that if you do not have a standard feeding policy in your neonatal unit, you are more likely to see NEC. If you have a standard feeding policy, the incidence of NEC is much less. Now, the interesting fact is, when does NEC occur? The most frequent period is between 25 and 33 weeks of gestation. But at diagnosis, it is very interesting. The earlier the baby is born, then later the baby develops NEC. So if a baby is born at 23, 24 weeks, you will not get that baby developing NEC for nearly a month. And if a baby is born at 29 or 30 weeks, the baby may develop NEC 2 or 3 days later. But at term, if the baby has significant risk factors, that particular baby may develop NEC within 1 or 2 days, or even within the first week. So the message here is lower the gestation, later the NEC. But the question is, why is this so? Think about it. The reason is that in preterm, NEC is mainly due to immunoreactivity, whilst in the term and near-term infant, NEC is mainly due to vascular reactivity in the large gut. So NEC in the term, near-term babies is mainly in the large gut, and NEC in the preterm infant is mainly in small and large gut. We and others have raised a research question that are these 2 conditions the same with a similar clinical presentation, or are they 2 different? And let us see what the current opinion is. So to understand NEC, you need to understand the major players. And there are 4. There's a gut physical and chemical barrier. There's a gut microbiome, which Talal has spoken about. There's gut immunology and genetics, which is taking the first place in current thinking of development of NEC, and the gut-intestinal blood flow. Now, I think Talal has mentioned this already, but if you take a healthy baby, the healthy baby has got large mucus layer, which is both the thick and thin layer, is a large layer. which prevents the bacteria from coming in contact with the enterocytes. There are lots of Paneth cells which release the epidermal growth factor, so the enterocytes are growing. They also release the antimicrobial peptides, so that if there is any bacteria around, they are able to control those. There are goblet cells which secrete molecules which refurbish the mucosa, and the mucosa remains thick and impregnable to the bacteria. There is secretory IgA which binds to the bacteria. But if you take a premature gut or a gut of a baby with NEC, and one other important thing about the gut in a healthy gut, the enterocytes are bound together with very tight junctions. They will not let anything go through. Whereas in the preterm or in the babies with NEC, what happens is that first the mucus layer is very little and is devoid. The goblet cells are very few, so they cannot regenerate the mucus layer as much. The Paneth cells are very few, so there is less epidermal growth factor, then there's less level of secretory IgA. But what is very important, and that the tight junctions are very loose, and they allow the bacteria to go through between the enterocytes. But what is very important, and I'll elaborate on that in the next couple of slides, is that there is in the premature intestine, there is very high level of TLR4 activation. And I'll talk about that in the coming slides. Khalid has also mentioned about good bacteria and bad bacteria, and I don't want to take much time, but to say that good bacteria is responsible for maintaining the integrity of the gut mucosa and the epithelial cells, and in fact it helps in repair if there is any injury. If there is dysbiosis, there are more bad bacteria. They break the tight junction, the bacteria, they enter into circulation, there is dysregulated immune response. And what was being discussed, I think somebody asked in a question about the gut microbiome-brain axis, why does it affect the brain? But what happens is that these microbiome with their end products affect the growth of microglia and the astrocytes, which are developing at the same time when, in fact, the necrotizing enterocolitis period, or between 25 and 33 weeks, they are at the most vulnerable time, and that is why in NEC, particularly, they get affected, and you have long-term effects, which were mentioned last time. So the reason why they affect is because the astrocytes and the microglial cells, which are also growing at the same time, are affected by the gut microbiome brain axis. One last thing about microbiome in NEC, and this is a classical work, and I'm very proud of it because this work was done by Pami Mohan, one of my trainees who's now a professor at Baylor University in Texas. He showed that 72 hours or so before NEC clinically develops, there is a blooming of the bad bacteria, the proteobacteria. As you can see, the bad bacteria grows from here to the majority. So the good bacteria is squeezed out, and in fact, there is a huge blooming, just like the flower blooms, there's a huge bloom of protobacteria. Something else, which is just a passing mention because it's a review, I need to do it in a complete way. There are many genetic factors noted about, in NEC. Two are important. One is the IL-18, 607 and AA gene genotype, which is particularly seen in babies who go on to develop a severe NEC. And then there are babies who have less IL-4 receptor, which is a protector gene. It protects the baby from getting NEC by producing more Th2 cells, but the IL-4 receptor is much less. So there's less Th2 cells, therefore the repair is not so good. But what is the most important player? The most important player, as we know it today, is the TLR4. It is a pattern recognition family protein. Pattern recognition is these molecules recognize anything which is foreign. And they have polymorphic action. They both cause destruction if there are too many, and they also repair at the same time. So they have, and they are present at the surface of many epithelial and endothelial cells, and they normally remain balanced, and therefore they maintain homeostasis in the intestine and make and repair if there is an injury. But if there is the loss of balance, that is, the TLR4 is excessively activated or it is too much, then there is enhanced sensitivity to injury and diminished capacity to induce repair. So it doesn't induce repair. So the question is, what about TLR4 when necrotizing enterocolitis is seen? Now, this is a beautiful piece of work from Haque and colleagues, which has shown that the TLR4 is rising from, it starts to rise from about 23 weeks and takes a plateau around 35 weeks. And this is the period when you see more NEC. So we now know that there is a large amount of TLR, activated TLR in NEC in the period when NEC develops. And that is the reason why we see more NEC between 25 and 33 weeks. And there is, as I said, it is unchecked, it is activated, and that leads to NEC in premature gut. So that is the immunoreactivity of the preterm gut. What does it do? What does TLR4 do? It acts between the bad bacteria and incites a pro-inflammatory response in the intestinal mucosa. And once it incites the inflammatory response, the mucosa is diminished, there is a leakage, and the tight junctions become loose. The bacteria enter through the enterocytes, and the TLR4 is also present in the endothelial cells of the mesenteric vessels and the capillaries. And one of the actions or bad actions is that it suppresses the vasodilatation. You know, the endothelium of the gut or any blood vessel secretes nitric oxide, and nitric oxide is a vasodilator. TLR4 suppresses that, and so there is vasoconstriction. And once there is vasoconstriction, that is what causes necrotizing enterocolitis and necrosis. And this cycle keeps on going round and round in the preterm infant. The reason being that the preterm infant doesn't have the capacity to down-regulate TLR4. So you have a problem in a baby who has high level of TLR, has excessively activated TLR, causing the damage, suppressing endogenous endothelial mesenteric nitric oxide, causing hypoxia, and thus necrotizing enterocolitis continues in the preterm infant. The pathology is very similar but slightly different in the term infant. In the term and near-term infant is the failure of the compensatory autoregulatory mechanism. You see, when there is hypoxia, the blood is redirected to main organs, but there is the protection, autoregulatory protection. The gut tries to protect itself to increase its blood flow. This is lost, and therefore the babies term babies go on to develop, or term or near-term babies go on to develop NEC. They also have more endothelium, which is also a vasoconstrictor, and therefore the blood vessels constrict much more rapidly than yours and mine. Talal alluded to this. One of the major reasons for developing NEC is the abuse of antibiotics. Not only misuse, but an abuse of antibiotics. We tend to give antibiotics to far too many babies. And you know, the good bacteria are very sensitive to antibiotics, so much so that if you give antibiotic within 24 to 48 hours, the good bacteria die and the bad bacteria start to thrive. And so antibiotic is one of the things which one should avoid, as Talal has said, and unfortunately, this does not happen in our country. This is a prescription from a tertiary care neonatal unit prescribed by one of the doctors to treat suspected NEC. I'd just like to pause on that and say that I cannot program people to make rational decisions, but I can only at least try to eliminate irrational decisions. I mean, look at this prescription and just have a conceptual view of this baby's microbiome, whether it is in the gut, whether it is in the lungs, whether it is in the urethra, whether it is anywhere. What would it be doing? This is absurd. Now, I talked about transfusion-induced necrotizing enterocolitis. This was a very well-recognized theory. In fact, there were meta-analyses showing that blood transfusion or red blood cell transfusion is associated with necrotizing enterocolitis. Recently, a paper published in Blood Transfusion Medicine by Ravi Patel has shown that it is not blood transfusion per se, it is the anemia. If you let the baby become severely anemic, that is what, there is then intestinal hypoxia, the tissue oxygen delivery is reduced, and therefore you then get necrotizing enterocolitis related to anemia rather than transfusion itself. So if I was to summarize the pathophysiology of NEC as we understand it today, you have dysbiosis, predominantly unfriendly bacteria. They enter through the enterocyte, increase TLR signaling, which causes reduced healing, mucosal breakdown, enterocyte apoptosis, and then the bacteria enter and translocate into the epithelium. There's endothelial TLR4 activation, causes vasoconstriction that leads to necrotizing enterocolitis. You can stop that by giving breast milk or probiotics or TLR4 inhibitors, but we'll talk about that in a second. So, ladies and gentlemen, enough science. Let us go to what is more practical bread and butter neonatology. It is not that recently people have said, Hippocrates said long time ago, all diseases begin in the gut. Signs and symptoms of NEC are non-specific. It can be very difficult to differentiate it from sepsis or from other gut pathology. There is abdominal distension, emesis, sometimes blood in the stool. You do an X-ray, you might find an ileus or intramural gas or biliary gas, but these are all non-specific. And therefore, people have started to work on developing tools to diagnose early necrotizing enterocolitis early. And there are tools which measure heart rate, saturation, and clinical signs. There are scoring systems. There are nursing tools. But it's a tool which is taking predominance these days is the predictive tool based on 9 risk factors, so-called the gut check. But these are at the moment still undergoing larger studies than the reported ones. So yes, there will be some scoring system to be able to diagnose or decide what baby has NEC and what grade it is. But from a practical perspective, let us be very simple. Thrombocytopenia is a highly sensitive marker of necrotizing enterocolitis. Unfortunately, it has low specificity. Nearly every baby with necrotizing enterocolitis will have thrombocytopenia because the platelets go and adhere at the necrotic part. The intestinal fatty acid bind protein is highly sensitive and highly specific, but not universally available. Interleukins, sensitive but not specific. Calcipoprotein, high specificity, no sensitivity, but a recent test of measuring the epidermal growth factor in the saliva of the newborn has a high sensitivity and a high specificity, but that again, test is not universally available. We all do a plain X-ray abdomen, but in fact it is not very sensitive. About 30 to 40% of perforations are missed and 30 to 40% NECs are missed. So yes, we all do them, but they are not very sensitive. Ultrasound is better, much better, particularly if you have Doppler with it, but it is operator dependent. You need to learn, you need to be taught how it should be done. Once you make a diagnosis of NEC, you need to be very clear at what... Hello? Hello? Yes. Sorry, I'm sorry. I don't know where the disturbance comes from. Once you make a diagnosis of NEC, then you need to classify it, and we have done that in our paper. You can look it up. And I don't need to spend much time, but it's very simple: suspected medical or surgical NEC. Now, the last bit of my talk: what do we do when we make a diagnosis of NEC? Believe it or not, I've been doing it for 55 years. Nothing has changed. Nothing has changed for 55 years. The basic principles are normalizing the hemodynamic if the baby is in shock, or if the baby is hypotensive, we give fluids and things, minimizing the progression of disease and removal of dead tissue. How do we do that? We rest the gut. We all do that. Cessation or reduction of feed to minimize bacterial translocation. But we do not know for how long. We have no idea. Reduction of infection. We give antibiotics. Which ones? For how long? And whether we should include antifungals? No idea. Removal of necrotic gut. Whether we should do laparotomy or whether we can drain it first, put a Penrose drain. Again, opinion is divided. But what opinion is not divided upon is that human milk reduces inflammation and repairs intestine. Hence, human milk, particularly if you have colostrum, if you start with colostrum and then give human milk, that will reduce your incidence of NEC, zoom, like a stone falls from a building. We had some questions about probiotic, lactoferrin, and the human milk oligosaccharides, and I'll show you a slide about these in a minute. And then lastly, the neuroanti-inflammatory treatments like the amniotic fluid or stem cell therapies. Now, we all rest the gut, and we give TPN. Now, once we're resting the gut, as I indicated earlier, there is a greater chance of translocation through the enterocytes. So the shorter the period we can keep the baby on TPN, the shorter the period we can keep the baby on NPO, the better it is. Traditionally, people take like 7 to 10 days. Our practice has been 5 days, but in fact, there is no RCT available as to when is the best time to start enteral feeding. I may be totally wrong. If you do it for 10 days, you may be perfectly right. I have no idea. But what I know is for sure that breast milk is much, much better. And I'll show you one other point which may not be universally known. Breast milk, of course, reduces the risk of NEC by about 12%, reduces the risk of surgical NEC by 20%, and sepsis as well. So breast milk is something which we should all be aiming for. Now, this is very interesting. Why does breast milk work? The breast milk has the capacity to down-regulate TLR. Believe it or not, how wonderful it is that it actually can down-regulate TLR. It also increases secretory IgA. It has lactoferrin, as has been mentioned, which layers the enterocytes with and prevents the bacteria adhering to the enterocytes, and the oligosaccharides. Now, this is something which is very recent and something which we have only just discovered. That these oligosaccharides, there are many, there are about 200, but they are very specific to the mother and baby dyad. So, and that also depends on the mother and the baby, and also on the gestation of the baby. Now, as has been mentioned, the human milk oligosaccharides are much higher in preterm babies and in term babies. They have no nutritional value, but they are important in controlling the intestinal immunoreactivity and also the growth of good bacteria. But what is important and what has been only found out in 2020 by Masai et al. Is that a particular human milk oligosaccharide DSLLT, it is much lower in the mothers whose baby go on to develop NEC. As you can see here, the DSLLT in milk of mothers who had low level of DSLLT, you had more necrotizing enterocolitis. The lower the level, the greater the severity of NEC. So we have now an opportunity to isolate this particular human milk oligosaccharide and see if it works in others. But in fact, it is so specific And it is specific for particular mother and baby based on its genetic. That in fact, if you look human milk, donor milk oligosaccharide, it is not as effective as the mother's own milk. So for preterm babies, particularly those who have risk factors, it is so important to give mother's own milk. As I said, you should have standardized feeding policy. Particularly from Australia has shown that if you have a standardized feeding policy, they were able to reduce the incidence of NEC by 87%. Probiotics was discussed. Probiotics has got many factors to support its use, and the last meta-analysis showed that if you have a particular set of bacteria, then it reduces the incidence of NEC and it reduces mortality. But there is a huge transatlantic divide. And here you can see that in North America, it's used about 13.7%, whilst in Europe, about 40%. And as Khalid was saying, only last year, 2 years ago, the use of the American Academy of Pediatrics issued guidelines for the use of probiotics. They said the current evidence does not support the routine use of probiotics. As opposed to that, in Europe, they now have got large data which has shown that the NEC incidence could be lowered, has been lowered since the routine use of probiotics, even in babies less than 25 weeks or 25 to 26 weeks. So there is a divide. You can make your own decision as to whether to use probiotics or not. But the numbers to treat are about between 30 and 60. So you have to give probiotics to a large number of babies to prevent NEC. Surgery, whether to put a drain or do laparotomy, well, the surgical incidence of NEC has not changed. Surgical mortality from NEC has not changed. Drain versus laparotomy, these are American figures. No difference till 2017. Even the 2021 figures do not show any difference between surgeons are equally divided. There is a recent small study of 94 babies from UC Davis, which has shown that initial laparotomy is slightly better, but we'll have to wait for a larger study. We all know necrotizing enterocolitis has got many issues, neurodevelopmental delay, survivor's impairment of growth, and all these are seen in babies who survive NEC. So how can we prevent it? There have been many trials, many modalities used, but the best modality, I think, is if you can do a quality improvement program in your unit to reduce the incidence. If you have a higher incidence of NEC, then as they did at Emory Hospital, University Hospital, where they reduced the incidence of NEC from 8% to 4% just by doing a quality improvement program. So in summary, ladies and gentlemen, prevention of prematurity, early and exclusive breastfeeding, standardized feeding policy, shortest period of TPN and NPO, appropriate and as short as possible use of antibiotics. Supplementation, arginine is important for gut nutrition on TPN. Consider probiotics, early surgery if required, and agents to reduce enterocyte injury. This is the second last slide. This is, to me, the most fascinating bit, which we are now going. Now we have realized that babies in utero do not get necrotizing enterocolitis. Why do they not get necrotizing enterocolitis? Because they swallow amniotic fluid. The amniotic fluid which they swallow inhibits TLR activation, signaling in utero, and it has large amount of epidermal growth factor, which it allows the gut to grow. It also has stem cells, so the enterocytes grow. And so this is now being tried, and I think this is something where the future may be good, that we will be able to reduce the severity and the mortality from NEC. So conclusion, despite 60 years of NEC experience, lack of significant improvement in overall survival remains elusive, and the bottom line is controlling TLR, preventing death of the enterocyte by whatever means you have. Thank you very much for your attention, and these are my references if anyone wants to look at.